The program will begin in 2 minutes. Please take your seats and silence your cell phones. The program is about to begin. Please take your seats, silence your cell phones, and turn your attention towards the stage.
Good morning. Good morning, everyone, and welcome. My name is Bill Salmon. I'm the Senior Vice President of Editorial Content at The Hill. I'm so delighted that you're here. I want to welcome everybody in the room and everybody who's watching us online to today's program, which is entitled Smarter Benefits, Redefining the Employer Role. Now, what does that highfalutin title mean? We're going to unpack all of that as soon as I thank our sponsor, Takeda, for their generous support in making this very important conversation possible today. So a sincere thank you to Takeda. You know, employers provide health coverage for over 150 Americans, including yours truly. So if you think about it, they're sort of uniquely positioned to drive meaningful reform across really the whole healthcare system. I mean, who is better positioned than the people who are providing the coverage to figure out how to improve that coverage? So as the costs of healthcare continue to rise and outcomes continue to be, shall we say, inconsistent, the role of employers has really never been more important. Fortunately, with advancements in medical science, data analytics, and digital health tools, employers are now really well positioned to champion preventive care, which is obviously important, improve outcomes, which is the most important thing, right? But also reduce costs, which, let's be honest, we're pretty interested in that as well, right? But to get to those things, you have to navigate through a series of rather thorny policy questions. I wrote a few of them down. One, how can businesses ensure their benefits truly deliver high-value care? Two, what policy levers can empower employers to play a more proactive role in transforming that care? And finally, three, how can the public and private sectors collaborate to ensure that innovations in employee health translate into actual better outcomes for all of us? Well, we will endeavor to answer those questions today and a whole lot of other questions, hopefully, because we put together an all-star lineup of lawmakers, employers, and health policy experts to really dig into some of these workplace-centered strategies that can honestly shape the future of American healthcare. But before we get into that lofty undertaking, we have a few mundane housekeeping notes, starting with, for those of us in the room, obviously we want to keep our cell phones set to silent for the duration of the program. But having said that, I want to welcome everybody to join in the conversation on social media. You can follow us on Instagram, X, Facebook, using the ampersand The Hill Events and the hashtag The Hill Health. Let me repeat those. Ampersand The Hill Events, hashtag The Hill Health. And with that, I'm so happy to introduce Christoph Weber, who is the President and CEO of Takeda, for some opening remarks. Let's give a warm welcome to Christoph.
Thank you, Bill. Good morning, everyone. Great pleasure to be here with you today. I'm really looking forward to that discussion, which is so vital and important for an employer like Takeda, but also for the evolution of the healthcare system in the US. I'm not sure if you know Takeda well. Very rapidly, we are a global biopharmaceutical company. We are one of the largest in the world, certainly one of the oldest. The company was created in 1781, so we have seen a lot in our history. We are a Japanese company, but we have chosen US as our really center of decision as well of activities. We are an R&D-driven company. We invest about $5 billion per year in R&D. 90% of our R&D activities is done from the US. Half of our global employees are in the US. We have our largest manufacturing network in the US, and of course the US is also our largest market as a business. We are present in 80 countries, and we are very much obviously involved in the US healthcare system through two lenses. The provider, we provide life-transforming medicines to the US patients, and the employer. We are self-insured employers, so we covered 20,000 employees in the US, and roughly 40,000 people actually are part of our plan. So it's a very interesting position actually to be both a provider as well as a user of the healthcare system in the US. So I'm really looking forward to the discussion today because it's really important for our industry, but I think for the world and for the pharmaceutical innovation to improve the US healthcare systems in the future. The world depends so much on the US healthcare system to discover the next generation of medicines. So really looking forward to the discussion. Thank you.
Thank you, Christoph. And now please join me in welcoming our moderator, Julia Manchester, who is a superstar national political reporter at The Hill. She is joined by Democratic Congressman Brad Schneider from the great state of Illinois, who just so happens to also be a member of the House Bipartisan Healthcare Innovation Caucus. So let's give a warm welcome to the Congressman and Julia.
Thank you, Bill, and thank you so much, Congressman, for taking the time to join us early on a Thursday morning in Washington. You know, policymakers are increasingly looking forward or looking to employers to drive healthcare innovation. From your perspective in Congress and on the committee you're serving in, how effective have these employer-led wellness programs and value-based strategies been?
Well, let me take a step back. And before I came to Congress, I was in business. And it's hard to believe that almost 30 years ago, I had my first opportunity to lead a business. It was a small insurance agency. I had a partner who took over this business. There were the two of us, and we had eight employees. And the tradition of the company we acquired provided 100% insurance, which we liked about that. So we provide 100% for our employees. And so this was 97 to 2003. Over those years, premiums kept going up.
Right.
And we kept having to look at what we could afford. Eventually, we included had to include our employees in sharing part of the cost of coverage. The cost of coverage had risen to more than $10,000 per employee. That was at the turn of the century. can't believe we're talking century. Today, that's more than doubled. Right? So every employer is looking at a benefit they're providing their employees that is extraordinarily expensive. And one of the things we found, it wasn't necessarily valued. Right? Healthcare is critically important for every one of us. We should all have access to quality care from providers we know and trust where we live when we need it. But if you don't need it, you don't really see it. So the importance, employers are looking for ways to give that benefit, to recruit the best employees possible, to retain those employees, to give them the opportunities to grow. And health is a big piece of that. Healthcare is a big piece of that. So we have to create this ecosystem where employees are getting something they value, employers are able to provide what they need to get the workforce that they desire to drive our economy, to create those opportunities. So it's critical that we provide that. It's been tough. It's been tough for employers. I know it as an employer. Coming here now, being in Congress, I was first elected in 2012. I joined the Ways and Means Committee in 2019. And we are constantly trying to find ways to bend that cost curve down while raising the quality of care and providing that. And employers taking the lead, employers working with their employees becomes ever more important in delivering that quality of care that I think every American should desire.
Right. You know, I want to zero in on the issue or topic of public-private partnerships. Obviously, these take place between employers, federal agencies, and health providers. You know, how might that streamline innovation in that space?
So, two questions combined.
Yes.
Because innovation is critical,
Yeah.
right? We have to drive innovation if we're going to find new ways to deliver care, trying to create the value that's necessary to provide that care. And the partnership, it's a multi-way partnership because you have the employers, companies who are just trying to get the strongest, best workforce they can deliver. Policymakers, you know, now that I'm on the other side of the table, our goal is to try to get as much value out to American citizens that they can get the health care they need at a cost we can afford. And the whole system working together, you know, it's if not the largest, one of the largest expenses for a family. It's a critical expense for the federal government. How are we bending that down? So the more opportunities we have for innovation at the company level, people coming up with ideas, taking those ideas, broadening them out at the employer level, innovation at, you know, there are a lot of companies out there are trying to put together a package, the care organizations that are driving that, the providers, working with providers to give them the opportunities. So I think that partnership where we can have the government, one of the things that CMMS does, that even the NIH and other agencies investing in research that looks at ideas that work, ideas that almost work but not quite there, and getting them over the hump to work again. All of that has to be, I think, a part of the package.
You know, I want to stick with the question of innovation. Are there any particular, you know, parts of innovation, ideas that you're looking forward to or excited about in this space? I know later on in the program we're going to be talking about AI and artificial intelligence. I mean, what are you looking forward to in that space?
I'm smiling because, you know, talking about this, businesses I worked with and worked for, we've been talking about that breakthrough innovation for decades. I think we're on the cusp of a real new opportunity, and you touched on one of the key drivers of that, which is artificial intelligence, the ability to take big data and bring it together, look at it in different ways. And if you almost think of it as a Rubik's Cube, sorting that, but the colors aren't there. You have to kind of identify the best way to do it. AI provides that. AI provides the ability to process extraordinary amounts of data in a very quick way with new ideas. It doesn't replace the innovation that's going to be coming from individuals and companies. So we've got to create that opportunity for AI and the guardrails around AI, which will be critical for Congress to get right, to provide the resource for businesses and entrepreneurs to come up with those new ideas. So AI is probably the thing I am most excited about.
Are there any concerns potentially with AI? I mean, I know that oftentimes conversations surrounding AI and data, there's kind of two sides to the coin. I mean, how do we, I guess, cautiously approach that?
Of course there's concerns. We're talking about data, we're talking about personal healthcare data, keeping that private and anonymizing. See, I knew I couldn't get it the first time. We were talking yesterday, I got it right the first time. But anonymizing that data becomes important, but also being able to take an individual's data with AI and customizing the care that they need. All of that we have to find ways to track out. Raise your hand if you have a device, whether it's a watch, a phone, or something that has some of your own healthcare data. Okay. Next year, I guarantee everyone will have something, right? It's coming, and it's coming fast, and it's improving the quality of care. You talk about innovation, we talked about the devices is going to be a big piece of it, but protecting that data is crucial. On the other side is AI. It is moving so fast and in so many different directions. It has, AI is artificial intelligence, but AI can also, they can stand for autonomous intelligence. And when you create these systems that can go in their own direction without the guardrails to protect first the data, but then the outcomes and the uses of that data, we have to make sure as policymakers, we're not stifling innovation, but as people with public trust, we are protecting personal information and things going off the rails.
Earlier in the program, or our conversation, you brought up agencies like NIH and CMS, I believe. What roles do you think these agencies should play in aligning public health goals with employer-based programs like preventative health care?
I think the first thing, the funding of the research, trying to create and expand the knowledge base, working to drive that innovation, and then disseminate that innovation. One of the things I think both CMS and NIH, as well as Congress as a whole, can drive is recognizing the importance of transparency and information, as well as education. So as a consumer, and the older I get, I become a more intense consumer of healthcare. As a consumer, it's hard to really understand what's the right approach. We can help with that, but what my options are. And the choices I make as an individual, the choices that are provided me, whether I'm an employee of a company or otherwise, or whatever community I'm in, affect the cost of care. So transparency, information, education, I think all has to be a part of it.
What is the conversation within Congress on this? I mean, is there a bipartisan appetite to move forward on this, or do you see hope there?
I always hesitate right now in this moment when we talk about is there a bipartisan appetite. The short answer is bipartisanship is pushed to the edges right now. Having said that, I can tell you, yesterday, if you watched what happened on the floor, the tragedy we probably just started, it was a hard day for our country yesterday. I don't care what side of the political aisle you're on. There is no space in this country, should be no space for political violence, and we should condemn it in every case, and I do. At the end of a very hard and long day, the last event I attended was a bipartisan dinner talking about fiscal issues. So those conversations are still going on. It's critical that we continue those conversations, that no matter how intense the debate on an issue may be. And I can point back to this summer as we were debating the OB3, it was very intense and very partisan. There were still, on the sidelines afterwards, conversations. We need to work to create a dynamic where we can bring those conversations to the forefront. So we are talking on health care. Health care right now is not at the forefront. Everything.
Right.
For so long this year, so much was on that one big bill. I'll leave everyone to choose their own adjective for the middle beat. As we come to the end of the year, there are healthcare issues that need to be addressed. And we've been talking about extenders. There's conversation in Ways and Means. Probably the biggest thing facing us in the healthcare space right now is the premium tax credit. And the challenge with the premium tax credit is where we started this conversation. One of the biggest expenses a family will have is healthcare, and health insurance is a way to manage that experience. But health insurance, as an employer, from $10,000 to over $24,000 today per family per year, that varies depending on the demographic of the family. The number that sticks with me, just because it's my age cohort, folks not yet at retirement age, a married couple, working hard but not making a whole ton of money, $80,000. If we don't address the premium tax credit before the end of the year when it's set to expire, their health insurance will go up $18,000 a year. Right? So think about that if you are trying to make ends meet. You're looking at retirement. Maybe you have 5 years before you retire. You're trying to protect your nest egg. And an $18,000 annual hit is not devastating, it's debilitating. So right now, the thing we have to do most is address the premium tax credit. The bill this summer, the OB3, is going to knock an estimated 12 to 17 million people off of Medicaid. We talked about a long day yesterday. I met with the president of Cook County, the largest county, second largest county in the country, largest county in Illinois. 2/3 of their budget goes to health care, and 56% of their revenues come from Medicaid. You can just imagine what happens if Medicaid dollars are cut.
We're in a room full of people, who work within the Beltway or Beltway adjacent. A lot of viewers work in politics or policy. But I am curious to, about the conversations you've had with constituents back in Illinois, what you're hearing from them on this issue. Obviously, healthcare broadly is a major issue. But in terms of the employer initiatives and employer healthcare, how much is this brought up in your conversations with them?
So the employer-employee relationship is not brought up unless I bring it up, in most cases. If I'm talking to employers, it's more likely to get brought up in the conversation. It's just healthcare in general.
Yeah.
And right now, in the moment, what I'm hearing, and I'm hearing it a lot, and I'm hearing it when I meet people in my office, when we have town halls, but I'm also hearing it whether I'm seeing people when my wife and I are out to dinner, whatever the case may be, is don't take healthcare away from the American people. And I think that was the message with the OB3, the fact that it is the decision to target Medicaid and make it harder for people who are already struggling to make ends meet to access their health care was seen as not a reflection of what we should be doing or the values that the people in my district prioritize, and they didn't want that. Concurrent with that, because of the way the bill was drafted, the increase in the debt, there's a $500 billion cut to Medicare that's a part of this bill. So if I'm talking to seniors, that is their focus nonstop. So it really is the anxiety. The anxiety is high now. I think if you think of a graph where there's a line in the middle, above it is high anxiety, below it is everyone's feeling good about it. Long before I came to Congress, we have not been below that line. help policymakers understand that, that's why the conversations with the employers, the collaboration and communication with the policymakers becomes so important, because we need to understand not just the vectors that are coming out of the health data, but what are the broader economic impacts that it's having in our communities across the country.
I'm curious, how does mental health care and how employers address mental health when talking about healthcare as a whole, how does that factor into this? I mean, are you hearing that more included in the conversation?
So I'm hearing more of it in Congress. I've been talking about, again, the work I did before coming to Congress. Stick with me for a second. There's a saying that says in politics that yard signs don't vote. And that's probably true, but my comment was always yard signs make people happy and happy people vote. And that saying that I use in politics actually came from my experience as a business owner, as a business manager. Happy people provide better service, produce better products, make companies more successful. And happiness, broadly defined, you can look at all different ways about it, but in a work environment, Daniel Pink is an author who writes a lot about this, is how do we best motivate our employees is giving them autonomy, allowing them to achieve mastery in a job that provides purpose. He calls it AMP with an exclamation point. A lot of that is that feeling of, do I feel good waking up, going to work, and am I holding that balance in my life? Now, I asked everyone if you have medical devices. I could ask you if you got up this morning, you knew that you were going to get everything on your to-do list completed. And if anyone does raise their hand, I don't want to know, because the rest of us are struggling to do that. That's natural, but when it becomes overwhelming or all-consuming, it becomes debilitating.
Yes.
And so as an employer, I want to know that my employees are feeling good about what they're doing. They're glad to come to work. They feel they're getting stuff accomplished, and they're having that balance that they're coming back the next day refreshed. When they go on a weekend or when they take their vacation, they're coming back re-energized and recharged. And some people, many of us, need help in that. And this is, we can talk about telemedicine, we can talk about employee assistance programs. All of these are designed to make sure that our workforce is having that balance.
Right. Well, I just got the wrap sign.
Great.
For real.
My
Thank you so much, Congressman. I appreciate
Thank you,
it.
my pleasure.
Yes, a great note to end on. Thank you.
Please welcome our next guest, Congressman Greg Murphy, a Republican from North Carolina, a doctor and co-chair of the GOP Doctors Caucus.
Hey,
everybody.
Congressman, it's good to see you.
Good to see you.
I think the last time I saw you must have been on the green room for our Hill show on News Nation.
Yes,
Yes,
indeed.
very good to see you at some of our programming events again. Let's kick off with this. You're the co-chair of the GOP Doctors Caucus. What initiatives is the caucus currently prioritizing to improve healthcare quality, affordability, and access?
Boy, you know, I could sit and talk for 3 hours on that. It would be a good one. I actually still see patients. So I'm the only one that's in House or the Senate, doctor-wise, that still sees patients. I do it because I love what I do. I think my patients appreciate it. But as equally important, I think it helps me stay in the trenches. We get a little bit cloistered up here. I think the term cubicle captains fits well from Washington, D.C., because we don't understand what's going on out in the real world. And so I'm literally, this morning, I just came from our Doctors Caucus meeting, got a text from one of my colleagues back home, we need more doctors. We have a huge doctor shortage, and it is a dereliction, I think, on the leaders of medicine in the last 10 and 15 years to not understand this calamity was coming. It's an article put out by JAMA 30 years ago said there's going to be a surplus of doctors, and so they cut a lot of the slots back then.
Wow.
They had no clue what was going to happen. So access is a huge thing, meaning that people actually want to see a doctor or be able to see a doctor. We've done a great job in growing what we call our APPs, our advanced level practitioners, nurse practitioners, physician assistants, to help with that workload, but they are not doctors. They're not surgeons. I'm a surgeon, and they can't do that in the operating room. So growing our ability to put forth a workforce in a growing aging population. You know, look, I've actually spent more in healthcare in the last 18 months than I did in the last 50 years. But as we get older, we require more and more health care. So we need the people, physicians, to be there. How do you do that? We're having a real problem with a brain drain in our rural areas for physicians not being out in rural areas. I live in eastern North Carolina, Outer Banks. Who's been in the Outer Banks? Everybody's been in the Outer Banks? Everybody's been in the Outer Banks. Thank you. Please come more, spend your money. But that's an extremely rural area, and we don't have physicians out there. We used to have folks that would set up their shingle and be there for their entire career. The money's not there. There are Medicare, Medicaid populations that literally don't pay the bills. I don't know if any of you guys ever run a business, but if you buy a hammer and you try to sell it for $1, but you had to buy it for $1.50, you don't stay in business very long. And that's what we're dealing with Medicare and Medicaid. They simply don't pay the bills. So being able to pay physicians, literally the cost of care is what we're fighting for with Medicare, because it just doesn't do that. If you look at over the last 20 years, the reimbursement for physicians for Medicare patients has gone down, inflation adjusted, 33%. It's kind of like what Congress, we didn't get any raises, but we didn't get cuts. Physicians have gotten cuts and cuts and cuts. So if you're in those areas, which is heavily Medicare, Medicaid dependent, you can't keep the doors open. You can't pay your staff. And I'll just end with this. I tell this personal story. I worked so hard to keep my practice alive, my surgical practice. We're literally the busiest urology surgical practice in the state of North Carolina. I tried so hard to keep that open. The day I had to resign to come to Congress, I turned to my next senior partner and said, okay, well, here you go. Here's the keys to the place. This is how you do it. And he said, nope, we're not doing it. And I said, what do you mean? He goes, well, the hospitals made us an offer. And I said, okay. And he goes, well, and he points out to the fact that 3 out of the last 8 quarters, we had not taken a salary. Because we literally didn't have enough money coming in. After you pay your staff, you run a business, you pay your staff first, you pay your rent, you pay this, you pay yourself last. And so people now, physicians are moving to hospital employment, which is a much more expensive place of care, and it's also a much less efficient place of care. So if I had to say on 3 things, it's access, it's physician payment, and it's the destruction of healthcare delivery by vertical integration in the country.
And going back to the doctor shortage, that has to do with the just not being able to keep the doors open, essentially. Is that the broad? Well,
I mean, the doctor shortage really more is we're not graduating people to practice. One of the real critical things, if people have to really hone down on this. We also have physicians who are coming out of medical school that don't practice. It may come out for 2 or 3 years and stop practicing. If they want to have a family, whatever, wonderful, but they don't practice anymore.
Yeah.
Or they'll practice 2 or 3 days a week, or they'll have some other venture. That's great. You should have never gone to medical school if that's what you were going to do. You should have been a PA or a nurse practitioner or something. You took the slot of someone who was going to practice for 25 years. And that has been the major factor, I would submit, in the reason why we have, other than they cut the spots, the shortage that we have today.
Right. I want to go back to Medicare regarding the recent funding bill. How are you going to continue to advocate for a permanent fix to Medicare physician pay beyond those short-term extensions?
Yeah, I've been here now 6 years, in 5 days, I think. Surgeons, we have a little different mentality sometimes. We're sometimes not the most patient people in the world. We see a problem, figure a plan, execute it, move on. It has been the bane of my existence up here to see every year a cut, and just a patch. It's driven me crazy. I thought, coming out of the House in reconciliation last year, had a good plan to try to all of a sudden take this downward trajectory and start it on an upward curve. Very slow slope. It was not a big slope, but it was at least a change in the slope. The Senate just took it out and just said, well, we're going to do another patch. We are pleading, begging, trying to do everything we can to fix this problem. This is a problem that is going to cost a lot of money, but I can give you 5 times as much savings in the healthcare system that we have now to pay for this. We have to reverse this trend. Because I have colleagues my age. I'm the elder age of 62. Used to be the doctors would normally practice till their 70s, sometimes 75.
Right.
I got guys my age or even younger just saying, hell with this. I can earn almost as much being an Uber driver. I can do something else and get rid of this. And boy, that just destroys the entire career of knowledge, everything that you have to be able to take care of patients. We just have to reverse this trend.
Right. I have to ask, you're in a unique position because you're a surgeon and you're a congressman at the same time. What's that like? I mean, that's got to give you a very unique perspective.
It is. It's kind of funny. I love to go back and put on my scrubs and my white coat. It actually makes me human again. About 6-9 months ago, I'm in the operating room. You have to understand the dynamic between the surgeon and the head circulating nurse in the operating room, because it's always kind of a, who's in charge, And I've worked with this gal for a quarter century, and I said, damn it, she was fussing at me, and I said, damn it, I'm a member of the United States House of Representatives. And she said, damn it, not in here you're not. Now shut up and do what I said. So it gives me my life back again a little bit. I love patients. And, it's the greatest job in the entire world. You get to meet people in a position where they trust you. You're trying to help them. Cancer is a horrible word, and it's the greatest profession in the world. It just gives me my life back.
Right.
Makes me feel normal.
Well, I hate to do this, but back to your other life in Congress. What policy levers do you believe that you and your colleagues in Congress should consider to support employers in offering, higher quality benefits?
Yeah, no, I think this is a real, we're kind of we're at so many different moments here right now. With RFK coming in, and I'll just call what he's doing a healthy disruption. Some a little bit more than others. I mean, I think there can be obviously some debate about what's going on. But what he's brought back to the forefront is the fact that we as a nation are not healthy. Comparatively, if anybody, I'm sure everybody here has read the Maha report, all 74 pages back and forth. It's some really staggering statistics about what we're doing as far as the health and welfare of our nation. If you look at the 55 million individuals who are covered by corporate employer health plans, that is such a captive audience as to how we can actually make people healthier. Now, in a competitive environment where employers, at least in my part of the world, are screaming for employees, what can they do? What can they offer? How can they incentivize their employees to get healthy, cut costs, bring something in, and keep them there? I think it's a very reasonable thing to do. And I think this is one thing where our employers, some really actually do it pretty well. I have a couple of boat builders in my district that do a fantastic job on employee health. And that only means physical health, mental health, and some of the other things. It's a big attraction. But I think giving folks reasons to not live in the world of fast food all the time, which I think is the biggest driver of obesity in the country, other than these damn things that are on our bodies all the time, these damn phones, especially with our kids. It's giving them a reason to eat healthier, to get out, walk, do things that are active, but become part of a corporate culture.
Right.
We have the whole world of corporate culture where we're, I don't want to say shoving things down people's throats, but it's an important mantra that we send home with people, not just at their workplace. You send home with people a different ideology. You make them healthier, the employer saves money.
Right.
Employer saves money, so it's really a win-win on everybody's part.
You mentioned mental health, and I asked Congressman Schneider about this earlier. How much of a are you hearing about mental health and the broader conversation about healthcare when it comes to employer-based healthcare?
Yeah, no, guys, we have a mental health crisis, and we knew this was going to happen coming out of COVID with all the lockdowns. We can litigate that at another time, but it's a big deal. You look at the recidivism rate of people who are coming in, new employees. I think I saw one report with new employees of the Gen Z folks that 20% were fired after 18 months because they couldn't handle the job. So it's a real mental health problem, especially disproportionately probably affecting younger individuals than older individuals. And you want stability in the workforce for your employer. You don't want to have to retrain people. It's expensive. It's time consuming. You want to try to pull people in, keep them employed, keep them doing their job well. But mental health is really, truly an issue now. We've become over-medicated, and I think this is also, you go back to where food and nutrition and physical exercise really improve mental health. So again, it can be a win-win for employers that they have some type of program that deals not only with physical health, but also with mental health. You know, we have in our big hospital, there's a lot of resources. You know, being in medicine is an extremely, extremely stressful thing. I don't know if y'all ever been in an emergency room recently. The nurses and physicians are running around like crazy there. It's an extremely challenging environment. Also, just gosh, the workplace violence that you see in emergency departments, patients go crazy sometimes. So offering them some off-ramp not only helps with employment, but more importantly, really helps them with their own personal lives.
Right. What's in this conversation that we have about healthcare, oftentimes artificial intelligence or AI is brought up. What's your view on that, and how should employers and doctors approach that?
Yeah, we just had a little chat about that. So I look at AI as being 4 buckets that's going to happen in healthcare. One is diagnostic, being able to figure out what's going on with people. Another is therapeutic, how do we treat them? Another one is research, how do we improve research? Another thing is the legal aspect, and I'll hit on each of these just very individually. Diagnostic, if you look at some of my colleagues who are pathologists, they look at slides all day and they look at patterns. That's a computer-driven thing, boom. That's 90% of pathology is going to be taken up that way. Therapeutics, we're going to be able to, hey, say, look on a screen. You walk into some places now, if the electronic medical record will listen to you and the patient and prescribe a note. Now, we've not gotten to the point, nor do I think we should, to saying, hey, this is what the recommendation is. But if everybody in here has Google MD, a lot of folks come into the doctor's office already knowing what's wrong with them, or at least saying they are, saying, hey, this is this, I want this drug. I hope we never get there. We will. Research is going to be critical. We do so many research studies now that require so many different lines of clinical trials. We hopefully will get to a point where we've learned from this in the past. This carbohydrate molecule does this. We don't need to do that anymore. And then finally, it opens up a huge legal bonanza. I just got through a meeting where the fellow was put down a little machine. Patients would call in, talk to an AI-generated, quote, nurse, be able to ask it questions, and the nurse would be able to respond. It's going to help with post-operative care. Is your wound okay? Is leaking this, that, and the other stuff? It's going to revolutionize medicine, but as we have to step back and always say, especially in this town, how are we going to pay for it?
Yeah, absolutely. Moving on, what do physicians want employers to understand about the realities of patient care? I think you touched on this earlier.
Yeah.
Maybe delve into that.
Well, I think it's important for physicians to understand, you know, when patients come in, there's a whole different motivation. I had a little brain surgery last year. They went in, took out a little pituitary tumor. I was supposed to be in the hospital anywhere from 5 to 7 days. At 2 days, I was like, get me the hell out of here. That's one side. You have other people that sometimes I'll have to remove the mattress from the patient's room because they just want to stay in the hospital forever. There's a motivation to get people healthy, but also to get them back to work. There's a fine line because obviously in this world of interventions and medicines, you don't want to push people back too early by any means, but you also have to understand there is a normal recuperation period. We're doing a lot better with so much interventions. Gosh, when I came through, somebody had heart surgery, you know, you had your chest cracked open and you were out for 6 months. Now you can go in, they go in through your groin, you get a stent in 48 hours, you're back at work.
Yeah.
It's just a communication as to what's a reasonable expectation. People do better. I think they truly recover better if they're back into their routine, if at all possible. Helping from a physician standpoint to have an employer understand that, not want them back too soon, but have them at appropriate time is best for everybody.
Right. Routine is very important. You know, you brought up rural states like your home state of North Carolina earlier, and we know that employer-sponsored coverage sometimes struggle to connect with employees with local providers in those areas. So how can employers bridge that gap?
There are, you know, in my part of the world, we've lost a lot of our primary care doctors, as I talked about. One of the great things is that some of our big employers, Hyster-Yale, which is a big company that makes forklifts, et cetera, in our district, they have nurses on site. And they'll have a physician that will come once a week to do checks, et cetera, if you need it. Having somebody on site is a win-win for everybody. Somebody can take a break for an hour, go see the nurse. If they're having a little headache, blood pressure issues, whatever. And that nurse can triage. get them back, say, hey, no, you need to go see a doctor, pick up the phone, try to get them in to see their primary care doctor that day or the next day. Or if it's something that can happen that can wait, a physician will come once a week to those places. It is in the world of, as we say, locum tenens medicine, which doctors travel around, it's a great, again, another win-win to have somebody on site, but it has to be economies of scale. You have to have enough employees to be able to do that. If you have a company, my practice, we had 50 employees. We were doctors because all the nurses would just come up and ask us stuff anyway. But if you have a smaller place, that's not really economically feasible, but larger corporations can have people on site. It really works wonders.
Right. I want to end on a positive note. We've been talking a lot about innovation in this space. What's one thing you're looking forward to when it comes to innovation in healthcare?
One thing, the things that, as I say, keep you up at night about physicians is making sure that people are able to get to a doctor, to be able to see a doctor. We're going to have so much now that is visible with AI. Telehealth is tremendous in our area. It was one of the huge wins, if you look at the silver linings of the pandemic, highlighted the great avenue of telehealth. My patients come from 2 hours north, 2 hours south, and if you look out at the coast, 5 hours or half a day one-way travel. For a 15-minute office visit, if I'm reviewing a lab test or if I'm reviewing a CAT scan or something, we can do that online. That's a huge innovation. It's a huge saver. Insurance companies don't want to pay for it because it does drive up utilization because you actually will go see the doctor rather than that. But that needs to stay. We're still working on reauthorizing this. It needs to be permanent and be done with it.
Absolutely. So. Well, Congressman Greg Murphy, thank you so much
for
joining me today.
Y'all have a great weekend.
It is now time for our panel discussion, The Employer's Role in Driving Innovation and Better Health. Please welcome Christoph Weber, President and CEO of Takeda Pharmaceutical, Leah Binder, CEO of the Leapfrog Group, and Anish Chopra, Chief Strategy Officer at Arcadia. A quick note from our editorial staff. Though Takeda is the sponsor of today's event, we felt they were an important voice to include in the editorial portion of today's programming. Welcome all.
Well, good morning, everyone. Thanks so much for joining me for the panel discussion following the two lawmakers. I want to start out with a broad question to all three. Christoph, we can start with you. Employers cover more than 150 million Americans. From your vantage point, what is the single biggest lever employees have to improve value and outcome in healthcare?
Well, first, there is employers have been relatively passive until now when managing the health benefits of their employees. But when ourselves, but also when I speak with my colleagues, everybody is now struggling with the growth of the cost. It's in double-digit territory for the majority of the companies. And therefore, it's becoming a significant issue, which is how can we improve the outcome of this investment? I don't think we will see healthcare costs decreasing. I think right. Our goal should be to reduce the growth. And if we could move from a double digit to a mid-single digit, it will be quite already huge achievement. But I think it's coming from there. And we know that the healthier our colleagues are, the better for the company, right? There is no doubt about that. So I think you will see more and more employers being much more active and innovative in the way to manage our health benefits. And more broadly, I think that the healthcare system could be transformed by the employers. It's much more difficult when you are a government to transform healthcare. I think it can be much more dynamic from an employer if the employer are catalyzing that evolution and making healthcare systems more performant and more innovative.
Right. Leah, I would love to get your take on that.
Well, I completely agree that we're seeing major change in the approach that employers have toward health benefits. I'm seeing a real shift. The health costs are going up again, and I say again because it's been we had a relative period of some, not decline, but some lesser growth, especially around COVID, but now they're soaring back up, and employers are alarmed by it. There's a great study by a business group on health. They do it annually to look at health costs, and they found that employers are predicting 9% increases in 2026. And if they take no steps to reduce their benefits, which they're going to do, so then if they do that, they're figuring it'll go up about 6.7%. So those are both alarming numbers. 6.7% compounded annually means that employers are headed in a direction that is absolutely unsustainable. Traditionally, the approach to cutting costs would be pass more costs off onto the employees. And certainly they're going to have to do that. That is part of the strategy, higher deductibles, copays, et cetera. But the other thing we're seeing that I'm really excited about is an approach to improve the quality of care, the value of care, the right price for the right care, and improve transparency so people are getting better care. And that is a very exciting approach because that will, in fact, lower costs over time. But it also improves the experience and the outcomes for all of us. It improves healthcare in general because it drives change.
And Anish,
Yeah, I'm going to place this more as a gauntlet than an answer, and that is it's the employer's opportunity to step up to the moment we're in right now to make a meaningful difference. And maybe I'll say three things to give you a little bit of context. One, let's state the obvious. In any given healthcare market, the employers individually are a minuscule fraction of a provider panel. So there's not a lot of scale for any single employer to make a difference. But when you aggregate, there's an opportunity to have a lot more influence. So point one is fragmentation's been a challenge. However, point number two, going back to the National Business Group on Health survey, the same survey that said there's a 9% inflation also said 90% or 89% of employers said their top priority this year is to help consumers navigate to the highest quality providers in the network. Why is that relevant? Because what we're seeing at the moment is that providers that have embraced some of the CMS or government-oriented programs to coordinate care, to establish bundles, are delivering differentiated quality at lower cost. Just employers don't play in that economic model, so there hasn't been a connection. So in this dynamic, there's a window of opportunity to kind of bridge what's happened on the CMS value-based care world and the employer world through navigation and routing. But here's the gauntlet, here's the opportunity. Not more than 3 weeks ago, President Trump hosted Apple, Google, all the major health tech companies, Epic, Cerner, all the major health CEO of the Cleveland Clinic. Everybody came to Washington to say, we will purposefully unleash a health tech ecosystem with three main objectives. Give every American the ability to have a conversational AI agent on top of their actual medical records so we don't have to scan our lab results and ask ChatGPT, is our health okay? Number two, they said we want to have a mechanism by which individuals can have some form of, let's call it digital check-in or QR code so we can kill the clipboard. So imagine an employee walking in and you just sort of scan like we do at the airport, our boarding pass, we scan, and all of our medical records transfer in pre-populate forms. And then three, in the area of prevention, for diabetes in particular, they said, let's work on ways in which we can give people virtual coaching. Not a single employer showed up at the White House.
wow.
That's an opportunity. If we bring employers into the health tech ecosystem, at this moment, we can awaken, I think, the most important voice to drive change in conjunction with, but not at the same pace of the government. So it's not gonna be government programming, it'll be building on the rails. In my opinion, I think it's an opportunity that we're gonna see in the next 12 months.
And I'm curious why aren't we seeing in those conversations? For example, you mentioned there was an employer at the White House.
4 years ago, and I'll get back to the two of them, 4 years ago, CMS mandated the first regulation on health plans to make data available to the individual. And the government could only mandate those rules on government-sponsored plans, ACA, Medicare Advantage, Medicaid. At the time, I was begging employer groups to join, because if you're doing IT work as a health plan, you do it across all lines of business, but the government mandated it only on, the government book. So literally, business leaders at the plans were saying, Anish, if I get a demand signal from the employers, I'm in. Nada. So they shipped the technology to do all this interoperability, but only for government book. Then the governor of California, Gavin Newsom, said, I'll do it. So literally, go to the Cigna webpage. We'll give the data to government patients of Cigna, ACA, but only commercial employers living in California because the governor signed a law. That's ridiculous. So today we can have the digital QR code and these conversational AI for government patients, Medicaid, ACA, but not employees.
Right, right. Christoph, back to you. In your role and work with Takeda, what are the current challenges you see as an employer with a large employee base in the U.S.?
Well, I think there is no question we will be more active, helping our employees to be more informed about what are the options to better manage the health services. I think there are two issues that I think are really something that we should fix in the US. One is price transparency, cost transparency, and outcome transparency. And this is a major issue to a scale that is relatively unknown, actually. So you take medicines used by hospitals, the price can vary from 1 to 7 folds in the same city. And we have exactly that example at Takeda with one of our medicines is used by hospitals, is charged to the patient and to the health insurance. The price varies by 1 to 7 fold, completely opaque. Within the same hospitals, the price charged to the patient can vary 1 to 7 fold as well, depending on what the hospital's price can be negotiated with the insurers. I think we need transparency on that, so that, because if you want to provide a choice, you need to be able to provide transparency about the cost as well as the outcome. It's a major issue. The second issue that we are having is that if we want to move into more predictive healthcare, preventive, we don't have enough data, and our employees don't have enough data. And I think this is something we need to crack, is how much data do we have access to in order to provide proper advice to our employees. We don't have genotype data, we don't have prevention data, we don't have health status data, and so we have a consumption data today. And that's a major issue to move into predictive healthcare.
All right, Leah, I want to go to you on this issue of quality. Employers rely on hospital and health plans, but they often don't have as much insight into quality. How can they push for those higher standards so patients can get the highest quality possible?
Well, they are pushing for transparency. So that is a very good point about transparency. Though they're pushing right now for price transparency. That's been a major priority for many of the employers we work with, certainly, and I know for many of the organizations like the ERISA Industry Committee, like Business Group on Health, have all been pushing for legislation around price transparency, and there is something in the House right now that the price tag for patients legislation that is really exciting, that would provide for much higher levels of transparency on pricing for consumers as well as for employers. But price transparency is not enough, and they recognize that. It has to be combined with quality transparency. Here's the fundamental reason. There is no good price for bad care. If you're going to get a bad care, you don't care how much it is. How much is an infection worth to you? It's not worth anything. That you don't want to argue about that price. You want good price for good care. And so getting at that issue of good care has been a really major priority for employers for literally 25 years. And they have been pushing for it. My organization, Leapfrog Group, is just an example of that, which was started for the express purpose of publicly reporting by facility on how good the quality of care is and how safe it is. That's what employers need to have now, and that's what they're pushing for in a variety of sectors, but they're also just trying to go out and get the data themselves. So I think that is what's, here's why I think that's new, there's something new about it in the current environment. Traditionally, the debate around healthcare has always centered on health plans and third-party payers, Medicaid, Medicare, how are they doing? And we say, well, if you have good access to care, that means you have health insurance. But health insurance is just a laminated card, or nowadays something on your phone probably. Health insurance isn't care. We have to look under that and say, well, what exactly is happening when someone goes into the hospital? And what happens to them there? Are they getting good care there? Because the truth is, errors and accidents, injuries and infections in hospitals are the third leading cause of death in this country. And we just never get to that conversation because we're so busy talking about health plans. We have to get under the hood because there's some real issues there, and people deserve to know who's doing the best job, where our employees are going to get the best care, and how we can improve that. And I think that's really a fundamental principle for employers, and they absolutely need policy to make that happen. They can't do it on their own. They absolutely need CMS and other policymakers to come in and say, yes, you're going to have transparency, we're going to enforce it. Just to your point, absolute transparency across the digital divide.
If I may, Leah has been leading this effort for decades, and it's been an important voice. If you don't have open underlying data, you can't run the calculations for who's high quality and low quality. So in 2019, we had just the inkling of a bipartisan effort. Senators Lamar Alexander and Patty Murray in the Lower Healthcare Costs Act of 2019 proposed a provision to create a national all-payer claims database that would have allowed us to study quality across the board for commercial and government-sponsored plans. We don't have that in the US. In the Senate Finance Committee, they got a majority of Democrats and Republicans to vote that provision out. And it was a modest investment. I think it was $20 million to sort of seed this thing and through a national nonprofit. We were this close. It did not make it into the final No Surprises Act. So we don't have a mechanism to pool the data on which to study the very thing that Leah has been championing, which has been, you've got to do what you can with the data you have, but it'd be better if we had full transparency. So maybe we bring that back if we're lucky.
Yeah.
But alternatively, if we get more employers to join the CMS health tech ecosystem, the very data that you're describing is now available in this negotiation that President Trump made with the health records companies. Prior to this an agreement, employers could not query for the medical records. First of all, there's a privacy question. Should you de-identify it, how, whatever. But mechanically, that would be releasing data for treatment, for payment. But today, we only release data for treatment. So under the Trump negotiation, the electronic health records company said, well, if the employers share the the paid data that you just said that you you may be able to get, for quality purposes, the clinical data so you can measure quality. Well, that's a great trade. And it'd be phenomenal to see, coming out of today's event, more employers aware that they can participate in this give to get voluntary initiative. The invitation is open. Everyone is welcome to that. I mean, look, I'm an Obama guy and I'm celebrating a Trump thing, right? This is an amazing world. That's what's available to us today to accomplish the mission that we've just heard.
You have a really unique perspective, having a background in both the government and private sector. So where do you see the biggest opportunities for employer-government partnerships on digital health? I mean, you mentioned
infrastructure. If the data flows, as you've noted, I think the employers will do a lot more with it faster, just because they're getting more novel, innovative, collaborative. So, but before, the data's been inaccessible. So number one, if the infrastructure works for the betterment of all, amazing, number one. Number two, I do think we're flipping the moment where Dr. Google moving to Dr. ChatGPT is literally going to change. And that just there's an opportunity, no pun intended, to leapfrog. So employers that distribute, AI-powered navigation may be faster to get people routed to the trusted best next place to visit, faster than it is delivered through a Medicare organization, maybe. So that's like a technical opportunity. And then three, I do think there's like this dream question, what is the definition of quality? What is the definition of what it means to be evidence-based, especially in an era where novel therapies and novel tools are coming to market? We can be a lot more agile in developing new definitions of quality and new mechanisms of measuring and disseminating the results of that information, so that when we bring GLPs to the market, we now have a mechanism to know, well, some are using it in a cost-effective way appropriately and others are not, and we can distinguish versus having a binary to fund GLP or not. And that's an opportunity that I see in front of us.
Oh, Christophe, you looked like you were going to say something. Well, in that case, I have a question for all of you. You mentioned Dr. Google and ChatGPT. I talked to the lawmakers earlier about how they see AI fitting into this equation. I would love to get your view, Christophe, and then you, Leah, on AI and how it plays a role in data here.
well, healthcare is about big data, right? So let's dream of a world where we have a very comprehensive data set in an anonymized way for all our employees. And this data set is enriched all the time. And then you have some AI model advising the person about what is the best way to manage their evolving health situation. I think that would be AI powered from an employer point of view. So, and again, it's all about prevention and prediction instead of just waiting for the treatment, which is very much too late. That will be AI powered. And so it's this ability to digest this data to provide the best advice for the future patients, but before they become patients. I think that's really how it should pan out, instead of just increasing the deductible and the copayment, say, well, okay, do what you can.
Right. And Leah, on AI, I mean, how do you view that?
Well, I think we look at AI particularly within hospitals and health systems. So while we are extremely supportive of efforts around prevention, and I do think the MAHA movement is disruptive in a refreshing way. Certainly controversies, and I won't get into those, but there's lots of, I think, important conversations that are happening as a result of it. Nonetheless, a third of health costs, roughly, are spent inside of hospitals. And too frequently, when we're talking about new innovations, we figure, well, there'll be post-hospital environments. I mean, most people think we'll make hospitals go away, we'll prevent people from needing them ever. People have babies, they break their legs, they have heart attacks. They will always need hospitals. And we need a strong and vibrant hospital infrastructure that's also more efficient and far safer for patients. So we like to look at some of the innovations in AI that are very promising for improving how patients are treated within hospitals or hospital systems, the broader systems, like with physician practices, et cetera, ambulatory surgery centers. There's some extremely exciting innovations, like ways that AI can go into medical records, and like Oracle actually, I think, is starting to work on this, as well as Epic, can go into medical records and help physicians and nurses predict when an error or an accident seems likely, or something's about to happen from a patient safety point of view, or when there's a medication error, they can grab onto it and alert somebody to it. Things like that can prevent enormous amounts of harm within hospitals that's happening now, so it would have an immediate impact. They can also synthesize through all of the sentinel events that are reported within a hospital and help clinicians make sense of it and begin to understand root causes better so they can address it better. As I said, during the course of a single day, over 500 people will die of a preventable medical error. So this is a huge area where we can have immediate impact. So we're pretty excited about the use of AI, but it has to be a financing system that makes it an incentive for hospitals to truly embark on that journey with their AI systems, and I'm not sure that's happening yet.
All right, Christophe, you mentioned preventative care and predictive care earlier, and I want to zero in on that a little bit. What would it take to make such a shift toward preventative and predictive care? I mean, it's obviously so incredibly important. How do we prioritize that?
Well, I think this is the only way to really reduce the growth rate of healthcare costs. Hospital efficiency, of course, is a big piece as well, but we need to move into predictive. There is prevention and predictive. Prevention is really eating well, exercising, sleep well. I mean, but predictive is about understanding how the healthcare status is progressively evolving towards a potential disease, and acting early enough, but to detect that slippage, if you like, that's trend. And I think we will have this capability very soon, because we talked earlier about sensor. I mean, pretty much everyone in the future will have not only a watch or a ring or whatever, but multiple sensors. But we need to collect this data and to analyze this data beside what is already used in the healthcare systems. So we'll be able to detect this trend and act early. And I give you an example, at Takeda, our biggest healthcare cost today is musculoskeletal pain, so back pain, and that's our number one cost. Well, you can predict that actually. Mental health you can predict as well, and so it's all about this prediction. But today we are not able to do that. We are not able to do that because we don't have access to that data, and so we need to clarify what type of data we are allowed to have. And it's anonymized but personalized. So it's if you just analyze your data saying my health status of my 20,000 employees in the US is X, you don't go very far. So you need to have anonymized but personalized data so that you can give personalized advice. I think that's really really important. And then of course, everybody eventually will use healthcare services, whether they are clinics, hospitals, fees. And that's where we go back to the price and the quality, right? Where is it better to go? And today it's completely opaque, right?
Right. Anish, we talked about digital health, AI, et cetera, but how can employers encourage faster adoption of those digital tools?
Well, I mean, let's build off of where Christophe went. I mean, literally, I couldn't be happier with your words, because if people pursued that in the employer community, we'd be in an incredible place if we kind of got the plumbing right, the data right, the privacy policy right. The key factor here is incentives. The power formula is opening up the data plus reforming the payment equals innovation. And so the payment incentive, if I were to sort of make a humble request of my employer friends, hug CMMI. This is the Innovation Center inside Medicare, which has the authority to test new payment models without having Congress micromanage it. It's the first time, I believe, Congress ceded its power to micromanage physician payment and allowed an executive branch agency to manage it. That one of the many gifts in the ACA was this sort of transfer of authority. So in the MAHA movement, I am very confident there's going to be a MAHA model that CMMI will design to create an economic incentive to treat back pain more in the preventive mindset relative to the maybe the more treatment-oriented. And so that condition-based bundle, where prevention is a key factor, if the employers joined CMMI to do a multi-payer test of a new payment model, when someone is initially diagnosed with back pain, there could be an expected budget. And if you, through wearables and coaching and whatnot, help people stay healthy without the need for surgery, those savings can be divided up between the providers who organized it that way and the employers who were underwriting it to come out ahead. So that type of shared economic model where the incentives are aligned to drive the prevention, that's achievable, and we will 100% confidence see a CMMI MAHA model. I mean, how could we not, right? This is RFK Jr. We haven't read the model, it hasn't come out yet, but they've identified this is a priority. If the employers join in that cause voluntarily, I think we're gonna see a big sea change in exactly the things Christophe described.
You know, I ended on a positive note with the two lawmakers, so I want to ask you all what you're hopeful for in this space. Anish, we'll start with you. You kind of alluded to it there, but what are you hopeful?
President Obama said, while Washington sounds massively attacking and negative, we operate within the 40-yard line. If you hear anything out of my voice today on this issue of data in healthcare, AI in healthcare, innovation in healthcare, and payment reform in healthcare, that's in the 40-yard line. So let's work together in the 40-yard line to bring this vision to life. I'm hopeful because we're seeing it. And to me, I see this as a natural extension of work that was started during our time, but call it whatever you want, it's moving in this direction.
Right. Leah?
Well, I'm excited about turbocharging a transparent movement in healthcare. I think by sharing the data with new technology, allowing consumers, individuals, to look at their own medical records on a routine basis, to correct them perhaps on a routine basis, and to have more tools for their own prevention, I think is incredibly exciting. It's going to depend on transparency. That is not easy. There are lots and lots of kind of undercurrents in the healthcare system and other places that want to restrict access to the kinds of data that people need. And that happens all the time. We are continually fending that off. So it's a recognition that we need the transparency and then somebody willing to fight for it. So all of us need to fight for it. We certainly need employers out there fighting for it. But transparency does not come easy in healthcare. And that's what I'm seeing that's most exciting about this new, I think, this new world of better value in healthcare.
And Christoph, finally.
Well, I'm very hopeful because we are facing a burning platform. The reality is that nobody can afford the healthcare growth that we are facing. So it's a good moment to reinvent what is the dynamic and the rule of the game. You mentioned transparency. It's correct. All the different stakeholders are against transparency. That's why it's probably the right thing to do in order to improve the system. And I think we need this transparency, and we need now to have access to this data to become more predictive. And I think we are in a unique moment with the burning platform, with the technology being there, and the willingness of employers to create potentially a competitive advantage vis-à-vis their competition. Because I think that the employer who will design a clever health benefit in the future will have a competitive advantage versus another employer in the same field doing business as usual. I think that would be interesting.
Well, thank you all for such an enlightening discussion. I really appreciate it. I think we'll exit this way. Perfect. Thank you.
That brings us to the end of our program. Thanks to all of our wonderful speakers this morning. On behalf of the Hill and our sponsor Takeda, we'd like to thank everyone who joined us here in person and those of you who tuned in online. If you missed any portion of today's discussion, the full event video is available on thehill.com. Thank you very much and have a great rest of your day.